So, morning everybody, it's nice to be here and thanks for the invitation. Actually, it's a bit of a new experience for me to give a talk for the data managers, because normally when we discuss chimerism we go into very much detail on all kinds of aspects of chimerism from a biological perspective, and I thought I shouldn't do that today. So I will give it a try. I will start, and as Henrik Jan said, I'd like to kind of invite you to actively participate and to interrupt me at each and any time. So let me make it kind of a more of a workshop-like session. To interrupt me at each and every time when you think, hey, clarify, or when I enter data in a registry, it doesn't match what you are saying, or I always get into trouble with these fields, and then I'll try to explain. So chimerism, it's a difficult word. If you type in Wikipedia, which is of course our main source of information, this is the definition, and that's actually what we're talking about. So chimerism, the presence, let's say, of non-self cells in an organism as a combination with your own cells. This is chimerism, how it looks like, I think, from a data manager's perspective. A lot of fields to add, and what I would like to do in the next half hour is to give you a bit of a flavor what is behind these fields, what is behind the numbers that you type in, and to give it a bit of a perspective. So it's all about this. So from a biological perspective, when we talk about stem cell transplantation, you all know stem cells reside in the marrow niches, and they give rise to a whole bunch of hematopoietic cell lineages that initially develop in the bone marrow and that finally make it to the periphery. So the lymphocyte lineage, the myeloid lineage, the red cell lineage, the platelet lineage, and the efficacy of this process more or less determines the outcome of your transplant, and it has a direct relation with how we assess chimerism. And what is, I think, nice to realize that there are different, let's say, waves or different phases of immune reconstitution or engraftment post-transplant. Of course, what we infuse in the patient, whether that is marrow, whether that is peripheral blood, whether that is cord blood, essentially it doesn't matter, because the hematopoietic stem cells or progenitor cells, if you wish, they reside here in this is a bone just cut in length. So you look at the inside of a bone. That's where the niches are. There the stem cells reside and give rise to all these populations. There's one exception, and that's the development of T cells. So T cells are not produced in the marrow. The precursors are, but the precursors, they travel, in contrast to all the other lineages, they travel to this specific organ called the thymus. If you make an X-ray of your thorax, you can see it at a young age. It's a nice shadow over here. This is thymus tissue, and that's essentially the factory where T cells are being produced. So with respect to the production of cells from their earliest period of time, so from their progenitor phase, from their stem cell phase, we have actually two production sites. We've got the marrow and we've got the thymus. And why that is important, I will come back to later on. So in a cartoon, the stem cells give rise to all these lineages, and this is what happens in the bone marrow and what you finally see is the end product in peripheral blood. This is where usually, when we talk about chimerism, where chimerism is being assessed. So usually, the vast majority of chimerism results that you are requested to fill in the database are peripheral blood chimerism results. And chimerism, and I'll come back to some of the technological aspects later on, chimerism can be assessed in whole blood. So you take a tube of blood, you bring it to the lab, and using the techniques that I will show later on, you will get a result. But you can also assess chimerism in different cell lineages to get a more detailed perspective. And that is especially relevant for genetic diseases. One example, and we'll come back to this when I show a few cases later on. If, for example, you have a disease called severe combined immune deficiency, and this patient gets a bone marrow graft, for example, from his brother or sister, and you infuse the stem cell graft into these patients without giving chemotherapy to get rid of their own cells, you have the patient's the patient's hematopoietic system, and on top of that, you will have kind of a seeding of the donor T cells on top of this, let's say, this broader perspective of recipient cells. So it's not a full replacement of the whole hematopoietic system, it's only a partial replacement of that part of the hematopoietic system that the patient itself is unable to generate. So in contrast to this situation, where donor hematopoiesis, for example in a leukemia patient that has been treated with total body irradiation or high-dose chemotherapy, is completely replaced in most cases by donor progenitor cells that give rise to all these cells, and they will in most cases all be of donor origin. In this situation you are talking about a completely different situation. So only part of the hematopoietic system becomes of donor origin. And that's what we call split chimerism. Sometimes it's a bit mixed up with what we call mixed chimerism. Mixed chimerism makes sense. You have a mixture of donor hematopoiesis and recipient hematopoiesis. And in case of split chimerism, we use this term to address the issue that only one lineage is being replaced by donor cells. So especially in this type of diseases, those genetic diseases, those immune deficiency diseases, it quite often happens that you end up with a mixture of cells in peripheral blood, where you have to do your chimerism analysis on. If you put it a bit black and white, and of course there is very much room for exceptions, if you put it very much black and white, you could say if we are transplanting leukemia, and I restrict myself to the pediatric part, but to a large extent it also holds true for the adult malignant diseases. The aim is to replace the whole hematopoietic system and end up directly or after some intervention with full donor chimerism, because we want to get completely rid of the disease with no chance of recurrence. In a lot of non-malignant diseases, it is not essential to have full donor chimerism to be able to speak about a successful outcome. Take the example of the previous slide. And I'll show a few examples later on. But it also indicates that it is very important to follow chimerism in those patients to see how the hematopoietic system evolves and which part of the hematopoietic system becomes donor origin and which one remains recipient origin. So why is it so important to monitor chimerism? Why would you like to know this? Why not just focus on your hemoglobin levels and your leukocyte levels and your thrombocyte levels? Well, of course, first of all, you would like to know, is there truly donor cell engraftment? There can be recovery out of aplasia post-transplant, but it doesn't say you anything about the origin of those cells. So if a patient has, let's say, 500 neutrophils at day 23, we call it engraftment, but we do not know whether that is recurrence of recipient cells that have survived the procedure or whether it's really donor cells taking over. So by measuring chimerism, you can make a distinction with, are those cells of donor origin or are they still recipient origin? A second important aspect is that it allows you to monitor the initial disease or the recurrence of the disease or persistence of disease, because the disease is recipient origin. And third, it allows you to monitor the impact of therapeutic interventions, for example, the administration of donor lymphocytes, to get rid of unwanted recipient hematopoiesis. And finally, although that is not commonly applied yet, but in principle, and I'll show you an example at the end, it might also allow you to monitor gene-modified cells, because those cells have obtained a different genetic makeup, so they can be distinguished from the recipient's original cells, because the genetically modified cells have a different fingerprint. So by using chimerism, you can make a distinction between the gene-modified cells and the original cells. So what kind of methodologies can you use? I just give a few examples on this. So when you look through a microscope to blood or bone marrow, you cannot distinguish whether these cells are host or donor. They look the same. So we should find tricks to find out who is who. Well, one way to do this, and it's already a very long-standing approach, still used, is to use the aspect of sex difference. So if you are a male patient and your donor is female, then the male cells and the female cells can be distinguished based on the presence of the male chromosome, the Y chromosome. So if you stain blood cells to detect with this fluorescent probe the male chromosome, you can distinguish cells that have no male chromosome from cells that have this male chromosome. So under a microscope, they look morphologically the same. But if you stain those cells with this male chromosome probe, you can see, oh, this cell has 2 X chromosomes, so it will be a female cell, or it has an X and a Y chromosome, it will be a male cell. And by simply staining and counting, and that's how we've been doing it for many, many years before more advanced techniques became available, you could say, okay, I count 100 cells, and of those 100 cells, 95 have the makeup of the donor, and 5% of the recipient, so we have mixed chimerism. A second approach is to use what we call flow cytometry. So that's a method in which you can stain blood or bone marrow cells with, again, fluorescent antibodies that recognize characteristics on the surface of cells. If, for example, in a genetic disease, a patient is unable to make a certain protein, then that protein will not appear on the surface of the cells. It does appear on the surface of the cells of the healthy donor cells. So if you do a analysis of the presence of this protein that should normally be expressed, but which is not expressed on the patient, you can follow post-transplant whether there are cells persisting or reappearing that miss this protein that should normally be present on your cells. And again, especially in genetic diseases, this can sometimes be a helpful tool. You can also use this, although it's not broadly applied, but it can be applied, to make use of differences in HLA. HLA molecules are on the surface of these blood cells. And if your donor has an HLA mismatch, you can, with this technique, make a distinction between cells that have one or the other HLA phenotype. So by analyzing these cells post-transplant, you can say, okay, this cell has the characteristics, for example, of a donor cell, and these cells have the characteristics of a recipient cell. So in time, you can nicely follow these differences. One of the most broadly applied approaches is DNA technology, where we make use of natural occurring differences in the DNA between individuals. There are a lot of differences between my DNA and each of your DNA, and with DNA technologies, you can analyze blood samples and make a distinction between a fingerprint that belongs to the donor or a fingerprint that belongs to the recipient. And then I'm not talking about HLA, but about other differences between individuals. And the latter approach is the most commonly used approach to assess chimerism. And in the lab, there are different methodologies, but in the lab, it looks a bit like this. So when you get blood from a donor, pre-transplant, you check for the presence of certain characteristics. Those are the peaks over here. So this is a fingerprint of how the donor looks like. And below, you see a fingerprint of how the recipient looks like. And you see that those peaks, they do not overlap. They are at different places. At least these two are the same, but these are different. So post-transplant, you can analyze blood samples, whole blood samples or isolated subfractions of blood, and analyze whether the peaks over here resemble the donor or the recipient, or whether there is a mixture. And then you can calculate which part of the blood cells have this characteristic, or which ones have the recipient characteristics. And based on that, you come up with a final result that you are being asked to upload in the registry, a certain percentage of these cells and a certain percentage of the other cells. And as you can see here, these are 3 different patients. They all have their different features. When we bring it more to a clinical example, so this is a patient before a stem cell donation. He's being treated with chemo or radiation. Stem cells are being infused. And post-transplant, you end up with a situation where part of the cells is still of recipient origin. You can see the blue lines over here. And part of the cells has become of donor origin. If this is a patient with acute lymphoblastic leukemia or acute myeloid leukemia, that is an unwanted situation because you want to get rid of the patient's hematopoiesis. And in those cases, in those cases, donor lymphocytes or other interventions can be applied to try to get rid of these residual recipient cells and to end up in a situation that is fully dominated by donor hematopoiesis. And this is an example of such a patient. So this is a patient transplanted for acute lymphoblastic leukemia. And here you see the timelines. About 3-4 weeks post-transplant is usually the first moment when I think most physicians will try to check chimerism. And in this case, we analyzed chimerism in two fractions, in the granulocyte fraction and in the so-called peripheral blood mononuclear fraction. And then for your help, I go back to one of the previous slides. So, meaning that we are, to simplify it a little bit, that by analyzing these two blood fractions, we analyze both this part of the hematopoietic system and this part of the hematopoietic system. Why not everything in one? And that is because we are interested how these two lineages behave, because they do not always reconstitute in the same manner. So if we go back to this patient, we noticed that that 80% of the peripheral blood granulocytes and about 65 or something percent of the mononuclear cells, so those are lymphocytes and monocytes, grouped together, that there was still room for recipient cells to survive. Well, you can imagine that in case of an acute leukemia, that is a very unwanted situation. So in this case, it was decided to rapidly taper the immunosuppressive agent, in this case cyclosporin, to no longer suppress the donor T cells, to give them the opportunity to fight against the recipient hematopoiesis as a graft versus recipient reaction. And you can see that during this tapering of cyclosporin, there is already an increase in the donor signal. There is still some residual patient cells surviving, but there is already something changing in this case. But it is not enough, because we want to end up with 100% donor chimerism. And since this persisted, we came back with additional donor cells, donor lymphocytes, to push the power of the donor immune system to fight against these residual patient cells. And several of these infusions were given, and finally the donor cells became so powerful that they wiped out the recipient hematopoiesis, and you finally end up with 100% donor chimerism. So this is, let's say, the clinical perspective. From a database perspective, from a registry perspective, I think it illustrates how important it is that you have sequential reporting on how chimerism evolves. Because chimerism at day 30 is not necessarily the same as chimerism at day 60 or day 100 or day 180 or 1 year post-transplant. So this is the reason why, particularly if you start with mixed chimerism, why it's so important to collect these data. For primary immune deficiencies and other genetic diseases, but I'll take primary immune deficiencies as an example because they are such a nice example, the situation is sometimes rather complicated. It's rather complicated for us, but I can imagine that must also be rather complicated for you if you have to enter the data and because it's quite often a mixture of percentages that you have to fill in. It may not always make sense. What are we actually filling in? And it might also be, and I'll come back to that, it might also be complicated to make the proper interpretation between filling in the chimerism results and filling in the fields whether your patient is in remission, yes or no. For leukemia, it's easy. If you have leukemic blasts, then the patient is not in remission. If a patient is 90% donor, but he has no blasts, then he is in remission. But how about a patient with a genetic disease that has a split chimerism or that has a mixed chimerism? Is this patient yes or no cured? Is he what field should you take in? I don't know whether you recognize this or whether you've been in such a situation before. Anybody been in doubt once? What to conclude? No? You've never had this problem? That's a surprise because we have it every week. So in genetic diseases, I already mentioned this in one of my first slides, genetic diseases quite often result in a block in the differentiation of cells coming from a stem cell or a progenitor cell. They make their differentiation to mature cells, and genetic defects quite often interfere with the development of these cells. So then most of the hematopoietic system may normally develop, but some cells do not develop well enough. And those patients need a transplant. And this is an example of a patient that had a defect at this stage. So the genetic defect resulted in a patient that was able to make most blood cells except for these final differentiation stages, mainly the CD8 positive T cells. So this patient was transplanted, and already from the beginning we noticed that starting up with a high number of cells, those were mainly the neutrophils and the early cells that reconstitute, monocytes. But as soon as other cells started to reconstitute in the months after, we saw that there was a drop in the level of chimerism in this patient. So we got a bit nervous. And the patient was doing fine. From a clinical perspective, there was nothing wrong. From a chimerism perspective, we got a bit nervous. And the patient continued to drop until about half a year post-transplant, and then stabilized at very low levels of donor chimerism. Then we went into more detail and we analyzed chimerism in these cells, and in these cells, and in these cells, and in these cells, and in some other cells, to find out which cells are actually of donor origin and which ones are of recipient origin. And then we realized that the cells that the patient was unable to make or inadequately able to make, that they were post-transplant mainly of donor origin. So from this cell lineage point of perspective, the patients could be considered cured. Although being mixed or mixed split chimera, is this patient cured? Because he has only very low levels of chimerism. Is he cured, yes or no? So then it comes, I think, to a very important thing that needs, I think, attention in the registry, is when do you call a patient cured? Survival is easy, but when is he cured? Or is he partially cured? So we checked the immune system of this patient, and she was perfectly able to make immune responses when she was vaccinated. She was not needing immunoglobulin support, and from a clinical perspective, there were no complaints. So from a clinical perspective and from an immunological functionality point of view, this patient is absolutely cured. But from a chimerism point of view, you might be in doubt. And I think especially those in the audience that are frequently dealing with non-malignant diseases, with those genetic diseases, this issue comes up quite regularly. Then another example, two kids in the same family. They were both suffering from again from an immune deficiency, severe combined immune deficiency. I won't go into the details. And this patient was, this girl was transplanted with an unrelated donor. She was receiving a reduced intensity conditioning regimen because of the young age and the disease. Post-transplant, she developed graft versus host disease, very prolonged. Finally, it got to rest. And not surprisingly, she ended up with full donor chimerism. She has no infections in follow-up. She has normal, what we call naive T cells, so cells produced by this thymus organ. She has normal functional assays, and she is not dependent on immunoglobulin. I think we will all agree that this patient is in remission or cured. Her brother transplanted, again with an unrelated donor, not the same, but another one, reduced intensity conditioning, no GVHD, and he ended up with a mixed chimerism situation. So some of the cells became of the donor, clearly the T cells and the B cells, because these patients are not able to make T and B cells because of their genetic defect. But some of the myeloid cells, the granulocytes, not all, but a substantial amount of them were still of recipient origin. This patient has no infections, has normal naive T cell output, has normal functional assays, and is not dependent on IVIG. So, same disease, similar procedure, full donor chimerism, plus overall conclusion, remission and cured. Slightly different post-transplant course with mixed chimerism, but based on these characteristics, in remission and cured. From 5 minutes? Okay, that's good. Then I'll skip this one. So what I would like to emphasize by these examples is that mixed chimerism is not the same as not being in remission. Cell lineage, so hematopoietic lineage specific analysis of chimerism might be very relevant in certain disease categories to make a proper judgment of whether the patient is in remission / cured, yes or no. And what we have to realize, and there are increasing examples of that partial correction of the hematopoiesis, so the patient will remain in part recipient will contain in part recipient hematopoiesis, and only part of the cells will become of donor origin. That may be sufficient for cure in quite a number of genetic diseases. And this is my final slide. I already mentioned in the beginning that gene-corrected cells, and there will be a presentation on gene therapy in the next session, if I'm well informed. If you genetically modify cells, you get an opportunity to follow those cells, because those cells have a different DNA makeup compared to the patient's own cells. And I'll just show you one example that is also, I think, very well known for those dealing with adult patients, but also children. And that's the example of CAR T cells. CAR T cells are everywhere, so I should end with CAR T cells. So the principle of CAR T cells, for those not familiar with that, is that you take the patient or donor normal blood cells, leukocytes, lymphocytes, and you do a gene modification, and I won't go into the detail, but you change the genetic makeup of those cells, and those cells will be able to make a protein express a characteristic on the cells that allows them to do functional responses that the non-transduced cells are unable to do. In this case, these cells are being converted into very effective cytotoxic cells to battle acute lymphoblastic leukemia. But those cells are distinct from your and my cells, because our cells do not express these genetically engineered products. So after infusion of those cells, these cells, either by the genetic analysis that I showed in the beginning or by the flow cytometry approach that I showed, where there's a difference in protein expression on these cells, you can follow the presence of these cells in the infused patients. And that is very important because this is actually the drug. These cells is the drug against the disease. So you can follow the presence of the drug. Of course, it's a cellular product, but it is the drug to fight the cells. So as long as these cells can be detected, you can expect that they might still be able to do their job. If a patient that has received those cells is no longer having these cells around, then there might be a risk that the disease that you are fighting is no longer battled and might return. And this will become an important thing, yes, often. This will become an increasingly important thing because in the registry we've been so used to register patients with hematopoietic stem cell transplantation, and that of course will continue, but increasingly there will also be a documentation of cells in whatever way gene modified as cellular therapy. And monitoring of cells modified by genetic manipulation will for you become part of the work, either in the setting of a clinical trial or in the setting of regular treatments. So be aware of that. Okay, so I hope that you've got a little bit of a flavor of what is behind the fields that you're filling in, that you have a little bit more information about what is actually happening in those patients, why we follow chimerism, how we do it, how important it is, and what we may expect in the years to come. That's where I would like to end, and I'm open for questions if there's time for questions.
Yeah, thank you very much, Arjan. I think there's time for one or two short questions. Is there anybody? Yes.
Yep.
There's a mic. There's a mic over there. Maybe it's useful.
Good morning. I'd like to know if you ever do chimerism studies in the bone marrow of these patients.
Yes, it's a very good question. The answer is yes, and depending on the disease. So, for example, and it depends a bit whether you do it on a routine basis or in the setting of a clinical trial. But, for example, in leukemia, it is not always, but let's say frequently used, especially in high-risk patients, to monitor chimerism, but also minimal residual disease, which is, of course, also a recipient signal because it's the patient's disease. And that is quite often used to monitor disease persistence or recurrence, and as a tool to decide whether or not to intervene with immunotherapeutic interventions. So the answer is yes.
Okay, thank you very much. I think...
Michael!
Oh.
You told me not to ask a question, but I actually really have one. What's your strategy for determining red blood cell chimerism in diseases where that's the one that matters, like thalassemia, porphyria, sickle cell disease?
Yeah, that's a good question. That is so we use let's say a routine approach, and we use a more innovative approach. The routine approach is that we simply check for the ABO typing. So if a patient is blood group A and being transplanted for thalassemia, and he will end up 1 year post-transplant with blood group B because the donor is B, then of course you can say there's red cell donor chimerism. But it is more complicated than that. You can also use the rhesus groups to analyze, and what we are doing in a more research setting is to also analyze the bone marrows with respect to the production of red blood cells, because there is a discrepancy between what happens in the marrow and what finally becomes manifest in peripheral blood. I think that was the question behind the question. Yeah.
Okay, thank you very much. We have to close the session. Thank you, Arjan.
Yeah. Thank you.